جمعية حشوات الجذور العراقية. هي اليوم طبعا ومحاضرنا اليوم هو أخ، مو بس ضيف، أخ عزيز، هو دكتور عادل العاني. دكتور عادل طبعا هو من خريجين كلية طب الأسنان جامعة بغداد، وطبعا مو أول مرة يعني يكون حاضر محاضرات للجمعية. شرفنا يمكن سنتين في مؤتمرنا وفي الكلية، فهو يعني just briefly I'm going to say a couple of words about his CV, which is very rich, I must say. He got his BDS from our college in 1978, then dental diploma in 1981 in conservative dentistry. Then he got his PhD from in UK, Dundee. Then he worked as an assistant prof in Malaysia from 1993 to 1996. In 1996, he was appointed as an endodontist in Dental Tuam Hospital in the United Arab Emirates. In 2014, he was appointed as a medical director at the Archer Dental and Dermatology Center in UAE. In 2015, he joined the Nova Medical Center, UAE Al Ain, as an endodontist. And in 2020, he was appointed as the head of the department at the Nova Medical Center. Of course, he's got so many things and many member and many associates in the endodontists, like the American, the Iraqi, the Malaysian, and the Emirati Emirates Endodontic Club. He's going to address a topic which is emergency endodontic treatment, diagnosis, and management. I don't want to take more of his time because I want to give all the time to our lecturer and friend. Dr. Adil, you may start, thankfully.
Thank you very much, Dr. Hussein, for your nice introductions. And it is my privilege and it's my honors that I will be with you this night. And really, I am highly appreciated your efforts during this courses of the endodontic through the year. And I am very sure that it is beneficial for each dentist in Iraq. Thank you very much, and this has given me an honors and the privilege and enthusiasm to be with you in this night. Anyhow, I would like to start today about one of the vital subjects that we are facing every day, and also it is a subject of the challenging of the daily practice as a dentist in general or as endodontist in our specialty. My topic today is emergency endodontic treatments. When we say that about the endodontic emergency is infringe or a breach on the tight planned schedule of the dentist as well as of the other patients, and tend to upset the follow of the day for everybody, including the patient, dentist, and the staff. The aim of emergency endodontic treatment is to relieve pain, as we know, and then to control the inflammations or infections that may be present. Although insufficient time sometimes may prevent ideal treatments from being carried out, the procedure followed should be prejudice and any final treatment plan. However, there is two issues for the dentist to be shown: the swiftness and the speed. And this is both of them. It is very important to create a very good treatment for the patients and to elevate the patient's pain. It is but natural that patients in bed must be rendered painless and comfortable as soon as possible we finish the treatment. Anyhow, when we are saying about what is it mean by the endodontic emergency, somebody expressed as a sudden or unexpected incidental demand immediate and needed immediate actions, or it's a crisis really, or it will be a chance to get a new or lose an old patient, and this is dependent about the behaviors and attitude of the dentist, how to deal with the patients. Other thing, there is really some of the study that the found, recent study reported that a 60 to 82% incidence of endodontic emergency, dental emergency, and within this group is 20 to 42% of patients seek care for teeth with symptomatic irreversible pulpitis, while additionally about 60% of the systemic irreversible pulpitis patients also complain of symptomatic periodontitis, while pulpotomy and pulpectomy have a greater than 90% success rate in the post-operative, in the relieving of the post-operative pain from moderate to severe to mild or no pain. However, while pain due to severely inflamed pulp is characterized by the dull, throbbing, and lingering pain sensations, it can be in two aspects. It can be spontaneous or in response to an external stimulus, such as hot, cold, or chewing. This makes systematic irreversible pulpitis the bulk of the emergency cases that we are seeing in our practice. So, however, irritations of the pulp causes inflammations. This is what is a general idea. And the level of response will depend on the severity of the irritants. It is a mild. The inflammatory process may be resolved in similar fashions to that of the other conservative, to other connective tissue. A layer of the reparative dentine may be formed as protections from the further injury. However, if the irritation is more severe with the extensive cellular distractions, further inflammatory changes involving the rest of the pulp and will take place, which could eventually lead to the total pulp necrosis and death. However, approximately 60% of patients with oral or maxillofacial pain are in need of the endodontic emergency treatment. The other one, nearly 90% of the patients, as Caroti in 2004, pointed that 90% of patients seeking of the dental emergency treatment have symptoms of pulpal or periapical disease. In this case, we give the definitions, and endodontic emergency is defined as an unscheduled visit associated mostly with pain or swelling ensuing from pulpo periapical pathosis required an immediate diagnosis and treatment. And I am going to concentrate it in my lectures about the diagnosis, how it is important in our daily practice, in our how to confirm about the treatment, or occurrence of the severe pain and or swelling following an endodontic treatment appointment requiring an unscheduled visit and active treatment, as Watson and Fuad in 1992. Also, the fact that there is something associated with emergency and urgency. And in this case, the pain is the most common factor that motivated the patient to seek dental treatment. Approximately 90% of the patients requesting dental treatment for the relief of pain have pulpal periapical disease and thus are candidates for the endodontic therapy. And this fact will be clarified in 1963 by Michel et al. However, there is, as mentioned to you, there's urgency and there is a true emergency. And supposed to make a differentiations between the two things. Urgency indicates a less severe problem in which the next visit may be scheduled based on what's convenient for both patients and clinicians. While a true emergency is the condition which requires and schedule visit with diagnosis again and treatment at that time. However, what is the key of the can be differentiated between the emergency and between urgency? First of all, is the problem such that it disturbs your sleeping, eating, working concentrations? This is an emergency condition affects this activity. While how long it has been bothering you, short durations emergency, with the pain of long durations are urgencies. Have you taken any pain medications or painkillers? That's our differentiation. Did it help? Medication are usually ineffective during an emergency condition. However, there is a three impacts. Emergency impact. We have included the patient and the staff and the dentist. And really, I am lucky to have a very good team with me working. I have a very good secretary. She can welcome the patients with the severe pain and take care of them with very nice smiles and with very nice, giving very kind attentions. And also I have the two assistants, Kim and Princess, both of them, they are doing very good job to me. One of them, she immediately take the patients to examine his blood pressures, temperatures, and during the COVID-19, they're checking also what is the patient, if he has any problems or if he got a COVID-19, and also they ask him to be sure to them that will be get the vaccinations, and also they ask him if he has previous illness of the COVID. She asked them to show us a 3 negative test of the PCR. In this case, they give me a very good support for the doing of my emergency when I got an emergency between the patients. However, the patient will usually present with pain, swelling, fistula or trauma. Patient view, acute pain, disturbance pain, uncomfortable pain, swelling, and also he came with fear for the clinic because this is the elevation, increase the pain and got it very thing, it makes the patients mad. Really, he cannot thinking only how to get rid of the pain. In this case, we must understand the fear of the patients during our treatments. While for dentist view, let us say disturb to schedule. We have a full schedule of the patients. They schedule when the patients can between the patients is disturbed our schedule, and also annoying to staff because the staff going to be take care of him and there is no time, especially if they have a coffee or they have a rest and there is some of the one come with emergency and pain. We need, this is feeling annoying. Even so to myself, I feel it's annoying to be honest with you. And also make a pressure to diagnose the case and to give the treatment. While us, with this short of time, we have very limitations to get the treatment for the patient. In this case, there is a 3D successful management, how to manage of the emergency cases by definitive dental treatment, by diagnosis first, then definitive dental treatment, and sometime if need, the drug. Treatment plan will be dependent on how to remove the etiology. And this is the etiology. It will be 3 types of etiology we're facing the etiology, like microbials, mechanical, or chemical. For the factor causing the pain are 2 types, chemical, chemicals or pressures. Chemical mediators, it will be direct or indirectly. Direct by activating nociceptors causing spontaneous pain or by lowering their pain threshold. Indirect by increased vascular permeability and produce edema. However, by the pressures, edema result in increase in fluid pressures, which mechanically stimulate pain receptor. Diagnosis, it is very important. Correct diagnosis is mandatory, really. Pick the right tooth and do the right procedure. I put this X-ray really for you to show you something. I was before in the committee of the qualify for the for especially for the endodontists who came and work in the Emirate. I was in the high authority of the health authority. I was in the committee, and I give this X-ray to the sometimes to the candidate, and I ask them, "You are by the chance patients came to you by the routine checking up? You find this is the heavy loaded of the restorations of the lower 7, and then you see there is some of the radiolucency hairs. What do you think the treatment?" And there is no complaint from the patient. Really, it is. I don't like to tell you the answer, but if anybody knows the answer, send it to Dr. Hussein, and I will give him from myself as a gift. To be honest with you, this is just a type of how we need to make a very good diagnosis without any mistake. In this case, no diagnosis, believe me, there is no treatment. We cannot do anything if we cannot get the correct diagnosis. There is something of the diagnostic to aid us. It's like periapical radiographs taken with a parallel technique, but don't do with your diagnosis on the radiograph. Radiographs, as I said to you, diagnostic aid just only, not you are looking for the X-ray and say, no, it is a pulpitis or it is something like this. It's a big mistake that most of the dentists, when they are patients enter to the clinic and they take the X-ray immediately and looking for the X-ray and give him the diagnosis. This is really, it is not a correct way of how to diagnose. And also there is a electrical pulp tester for testing the pulp responses. And also we use, and also for the thermal response, we use sometimes ice stick, hot gas temperature, cold spray, and hot water. And also we need that all the time with our side of the examination. We need a periodontal probe to measure the pocket, which will lead us if there is any fractures in the roots. Classifications. Really, I come to the classifications of the pain, of the dental pain. There is a different one and different. I am going to explain to you all of these. According to the Walton or Trubinijad, they give it 3 types: pre-treatment emergency, inter-appointment emergencies, or post-operative post-obturations emergency. While according to Cohen, he said thermal pain, percussion pain, swelling, spontaneous pain, aesthetic emergency. And this one, according to Cohen, he gave it before endodontic treatment, after initiations of the endodontic treatment, and after root canal obturation. While for the Gottsman, he depending on the treatment plan, he gave the 3 types. He gave vital pulse, necrotic pulse, and acute alveolar abscess. For the vital pulse, he gave reversible pulpitis, and irreversible pulpitis with localized symptoms, and irreversible pulpitis symptoms not localized. And then he gave the necrotic pulse and acute alveolar abscess, which is localized swelling or diffuse swelling. We shifted to the other thing, which is recommended by American associations of the endodontic. They recommended really new terminology. They depended on 2 aspects: on the pulp and the pulpal and on the periapical apex. In this case, for the pulpal, we have a normal pulp. Normal pulp, a clinical diagnosis category in which the pulp is symptoms-free and normally responds to the pulp tasting. This is the normal. While for reversible pulpitis, a clinical diagnosis based on subjective and objective finding indicated that inflammation should resolve and the pulp return to normal when the irritations will be removed. For reversible pulpitis, the pain is which is described by the American Association of Endodontists. The pain is of very short duration, does not linger after the stimulus has been removed. And also the tooth is not tender to percussions, and the pain may be difficult to localize. And the tooth may give exaggerated response to vitality test. and the radiographs present with a normal appearance. Other terminology, symptomatic irreversible pulpitis, a clinical diagnosis based on the subjective and objective finding indicate that the vital inflamed pulp is incapable of healing. Additional descriptors, lingering thermal pain, spontaneous pain, and referred pain. While asymptomatic irreversible pulpitis, a clinical diagnosis based on subjective and objective finding indicate that the vital pulse, the vital inflamed pulp is incapable of healing. Additional descriptors, no clinical symptoms, but inflammation produced by caries excavations, trauma, or during the cavity preparations. Other thing, the symptomatic irreversible pulpitis. I have this case really, he came to me and I found that two premolars, upper premolars with carious lesion. And this is, I can say, a clinical diagnosis based on the subjective and objective finding indicate that the vital inflamed pulp is incapable of healing. This is the first thing I noticed, and additional descriptor, lingering thermal pain, spontaneous pain, referred pain, and this is why I am go immediately to doing the root canal treatment for both teeth. Irreversible pulpitis, there is a history of spontaneous feeling of pain. And the duration is of this spontaneous feelings of pain from a few seconds to several hours. When hot or cold fluids are applied, the pain elicited will be prolonged. In the lower stage, heat will be more significant. Cold may be relieve the pain. When the tooth is converted from the cold, there is no to the hot feeling only for the heat. This will be converted to a necrotic pulp. Pain may be radiated initially, but once the periodontal ligament has become involved, the patients will be able to locate the tooth, and you can easily, he has told you where is the definitely the locations of the pains, and he pointed to the tooth itself. The tooth become tenders to percussions once the inflammation has spread to the periodontal ligament, and this is leading to the widening of the periodontal ligament may be seen on the radiograph after will be take all the history from the patient. Other thing, asymptomatic irreversible pulpitis, like we have the slower 6, a clinical diagnosis based on the also on subjective and objective finding, indicating the vital inflamed pulp is incapable of healing. We cannot heal the pulp. Already the caries is go through the pulp and make the extractions of the pulp. Additional descriptive, no clinical symptoms, but inflammation produced by caries and the caries excavation during to the removal of the caries, and sometimes by the trauma to the pulp, which is needed to do the root canal treatments. Another thing, we have a pulp necrosis, a clinical diagnostic category indicated death of the dental pulp. As I mentioned to you, that the irritations of the pulp start from the caries. When it's progress, it will be ended if there is no treatment and not remove the irritants factors, it will be lead to the death of the pulp. And this is what we call pulp necrosis. That is will be clinical diagnosis category indicate death of the dental pulp. The pulp is usually non-responsive to the pulp testing. When you do the pulp testing by the thermal or cord or anything, there is no response. Previously treated teeth, we are facing a lot of cases like this one. A clinical diagnosis category indicate that the tooth has been endodontically treated and the canals are obturated with various filling material other than intracanal medicament. Previous initiated therapy also, they are given another thing recommended by American Association of Endodontists. A clinical diagnostic category indicate that the tooth has been previously treated by partial endodontic therapy like pulpotomy or pulpectomy. And sometimes really there is a very nice papers as to by American Associations of Endodontists, and they are mentioned that the initial emergency treatment can we do pulpotomy if we have acute irreversible pulpitis, and this just to remove the partially of the coronal part and put some sedative. And I use this one really, and I put sometimes of material. I don't know if you are using it now in Iraq or not. It's called leather mix. The leather mix is corticosteroid with tetracycline. It's very good to subside the pains and also to relieve the pain and to get rid of the infection. There is an apical, as I told you. We say pulpal, and the American Association of Endodontics gave another thing is called apical. Apical, normal apical tissue teeth with normal pre-radicular tissue that are not sensitive to percussions or palpation tests. The laminate surrounding the tooth is intact, and the periodontal ligament space is uniform. There is no any swelling of the periodontal ligament. Symptomatic apical periodontitis, inflammation, usually of the apical periodontia, producing clinical symptoms including painful response to biting and or percussions or palpation. It might or might not be associated with an apical radiolucence area when you are looking for the X-ray, the periapical X-ray. And also there is another thing, that asymptomatic apical periodontitis, inflammations and distractions of the apical periodontium that is of the pulp origin, appear as apical periodontal, as an apical radiolucence area and does not produce clinical symptoms. There is other thing is acute apical abscess, an inflammatory reaction to the pulp infections and necrosis characterized by rapid onset, spontaneous pain, tenderness of the tooth to pressures, pus formations, and swelling of associated tissue. While there is another thing, chronic apical abscess, an inflammatory reaction to the pulp infection and necrosis characterized by gradual onset, little or no discomfort, and the intermittent discharge of pus through an associated sinus tract. And I am going also to explain to you in my next slides about the sinus tract and about the swelling. Condensing osteitis, diffuse radiograph lesion, represent a localized bony reaction to low-grade inflammatory stimulus, usually seen at apex of the tooth, and it will be considered as a normal. Management can be divided into the following steps for all of these. I think maybe you got it some confused about what I described for you about the different type of the pulpitis and about the American, about Gottman, about the Cohen. But really, this is, I would like in this matters to show to you everybody how characterized or how classified the dental pain during the root canal treatment or during the endodontic therapy. In this case, the management can be divided into the following steps when you are going for the emergency. First of all, I would be a proper attitude of all the staff, as I mentioned to you that I have a very good staff with me, very good team, and also to make an accurate diagnosis. I am concentrate on the diagnosis because it seems to me it is the vital, it is the key of the success of your treatment. Provide profound anesthesia during your treatment to keep the patients calm, and also promote an effective treatment supposed to give it to the patients. There is a proper attitude that it means there is a calm and confident professionalism should be displayed. You must be make your trust in yourself, make it confident in yourself, and show to the patient that you can control the patient. First of all, control the patients, because the patients came with fear, with pain, with everything, and your attitude. Hello?
الو
الو دكتور حسين تسمعوني؟ تسمعني؟
اي لا اسمعك كل زين.
Okay. Sorry about this one because I feel somebody is with me interfere with me and he asked his son if he want ice cream or something. I don't know whom. Give him ice cream, please. Make an accurate diagnosis. We'll come back to the make accurate diagnosis. Acute pain or swelling needs immediate relief, really, and the essential diagnosis should be rapid and accurate. Getting important medical and dental histories, because it's very important to avoid serious medical complications or allergic reaction or make modifications in your treatments. We have subjective examination and we have objective examinations. The subjective examinations, I will be just make a quick review. It means how the question relating to the history, location, severity, durations, character, stimuli, eliciting, relieving pain should be asked. All of this question to the patient. Listen to the patients, my dear. Don't just only when he say I have a pain, just you are take your handpiece and drilling the tooth and that's all. This is not a way of the treatment. We are professionals. We need to listen to the patients. When you are listening to the patients, they give the patient the treatment plan for you, and you can easily diagnose this. Not can will be treated only when take the handpiece or turbines and will be drilling the tooth, and at the end there is no beneficial effect from our treatment. And there is also objective examination, visual examination of the face, oral, and hard soft tissue. Dental examination should follow to note presence of defective restoration, discolored teeth, recurrent caries, fractures, like this one. And also we have to perform the vitality testing to note pulpal status. Thermal tests are more useful as they mimic the stimuli which elicit or relieve the pain. Also periradicular tests included palpations over the apex, and light digital pressures percussion should be done to identify periapical inflammation as the source of the pain. And also we have the periodontal examination. It's very important to check if there is a pocket, and the probing maybe helps in differentiate endodontic from the periodontal disease, because there is a relation between the between the perio and the endo. Radiograph examination, please learn to use them and not abuse them. I put it in the red just to give you this one, as I mentioned to you. Helps only the X-ray helps in detecting recurrent or interproximal caries, possible pulp exposure, resorptions, periapical pathosis, etc. And remember, radiographs are an aid to diagnosis, but not it is the diagnosis itself. So learn to use them and not abuse them. There is also differential diagnosis should be done to consider or rule out even non-odontogenic sources of pain which mimic odontogenic pain quite closely. Address the patient's chief complaint. Supposed to be if there is pain with biting, or pain with temperature changes, swelling, or sometimes if there is mobility or looseness of the tooth. Also, there may be other conditions or problems which become apparent during the exam, such as team joint pain, also, or myofascial pain or dysfunction disorder, neurological disorder, trigeminal neuralgia, vascular pain syndromes, and maxillary sinus disorder. These others should be brought to the patient's attention and ask the patients if he got it. Sometimes he say, when I am bending or when I am praying, there is some of pain. When I elevate my head, the pain is disappear, and maybe you need some consultations with the ENT specialist. In this case, I go back to the acute reversible pulpitis to make it in details for you. It is a mild, will be defined as a mild to moderate inflammatory conditions of pulp caused by the noxious stimuli in which the pulp is capable of returning to the uninflamed state following removal of stimuli. Clinical characteristic of the acute reversible pulpitis: a quick, sharp, shooting, momentary tooth pain, suggesting a buildup of alpha delta fibers, and sensitive to mild discomfort and pain, is traceable to stimuli such as a cold water or a draft of air. What is the causative factors? It may be recent history of the pulp capping, that sometimes they're putting of the dicles or other capping, or there is an exposed restorations, and there is also sometimes of the micro leakage, incipient caries or rapidly advancing carious lesions. Orthodontic tooth movement also create a pain. Periodontal disease, history of trauma, recent restorations. What is the treatment of in this case? We need only to the palliative treatment, such as we remove the filling and the placement of the zinc oxide e-joint cement as a temporary sedative filling is indicated in this case. If the pain persists after several days, pulp tissue should be extirpated and go for the root canal treatments. Diagnosis is by the patient's symptoms and the clinical test. Subjective symptoms: the patient's report of pain which is sharp, last of a few seconds, and disappear on removal of stimuli such as a cold, sweet, or sour foods. It does not occur spontaneously. Although the sudden attack of pain are of a shorter durations and may be continue for months. Dental examinations, when we go to the dental examination, may reveal there is a caries, or maybe there is a large restorations, or maybe there is a fractures and deep wear facets and the occlusal or recently placed restorations, or there is an exposed dentine. Pulp vitality test, thermal tests help to locate the offending tooth, but the cold test is preferable in this case. Percussion, palpations, and radiographs give normal status in this case. While electrical pulp test may give a slight or early response, radiograph examinations in these cases, if you are looking, it is normal. The treatment in this case, remove of the noxious stimuli, is normally enough. If a recent restoration has high spots, recontouring and adjusted the occlusion, and in this case will maybe relieve the pain. If persistent pain episodes occur following cavity preparations, maybe chemical cleanser of the cavity or a leakage of the restorations, one should remove the restoration and place also sedative dressing such as zinc oxide eugenol. If symptoms do not subside, then we are reached to the point that the pulp inflammation will be should be should be regarded irreversibly, and pulpectomy should be done for the patient to relieve the pain. We have hypersensitive dentine, and we have faced this one, and sometimes the patients came and complain about this one, and they are also attending as emergency, but it is not emergency, urgency, I consider it. It is characterized by the short, sharp pain arising from exposed dentine in response to stimuli, thermal, tactile, osmotic, or chemical, and which cannot be ascribed to any other form of the dental defect or pathology. Etiological factor in this case: exposed dentinal tubules due to periodontal surgery, tooth abrasions, erosion, and affrications. Treatment by the tooth side of the treatment can be block of the patient of the dentinal tubules by the physical or chemicals. Physical attempt to block the dentinal tubule with composite resin, varnish, sealant, soft tissue grafts, and glass armor cement. And also we can also use the system ionotophoresis technique, electrically device drives fluoride ions deep into the dentinal to occlude them and to stop this sensation. And also by the chemical desensitizing method, attempt to sedate the cellular process within the tubules with corticosteroid, or to occlude the tubules with the protein precipitate, a remineralized barrier, nitrate, fluoride, strontium chloride, or crystallized oxalate deposit, and this is will be sometimes of the toothpaste. We have these characteristics. Laser technology recently provide a definite solution for sealing of the dentinal tubes permanently, but this is the experimental stage, and the equipment for the laser, it is very expensive, which is not really recommended at the time being. We have a differential diagnosis condition that produce symptoms, namely those of the dentinal vicinity are Iraqi syndrome, fracture restoration, chipped teeth, dental caries, post-restorative sensitivity, teeth in acute hyperfunctions, palato-gingival groove, and while the acute irreversible pulpitis, we come to the other one, it is a persistent inflammatory conditions of the pulp, symptomatic, non-symptomatic, caused by the noxious stimuli. In this case, it is essential that this condition should be distinguished from the acute reversible pulpitis, which has many similar symptoms because the emergency procedure for each is different. If the patient describes pain that lasts for minutes to hours, as I mentioned to you, or it is spontaneous or disturbs sleep, or occur when bending overs during the praise or during doing an exercise, then the patients will require pulpectomy rather than the palliative treatment. Acute irreversible pulpitis symptoms can be localized or non-localized. The non-localized pulpitis poses one of the most difficult and challenging problem for the dentist. And since the patient cannot identify the offending tooth and he cannot localize where is the pain. In this case, for this one, the treatment will go for the pulpectomy, followed by insertion of the medicaments, cotton pellets, moistened with with material that's eugenol into the pulp chamber, and then place a temporary filling and prescribe an analgesic if necessary. Pre-medication or post-medication with antibiotic is indicated if the patient is medically compromised. If there is no sufficient time for pulpectomy is indicated. And as I told you, I use ladder mix. The ladder mix is very effective, really, and they stop the pain immediately. Acute apical periodontitis, really an acute condition that occurs before alveolar bone is resolved. One of the most difficult emergency conditions to treat is acute pulpitis with apical periodontitis due to difficulty in achieving required depth of anesthesia in such cases. There is complaint of the tooth feeling elevated in the socket or mobility in the socket or inability to chew on the particular tooth. Diagnosis, it will be very simple. And the tooth, when you are made a percussion, is standard to percussion. In this case, a radiograph of the tooth may appear normal or exhibit a thickening of slide of the periodontal ligament space or show a small peri-apical radiolucency. Causative factors, occlusal trauma and irreversible pulpitis. Treatment of this complaint, remove of the causative factors. If associated with non-vital tooth, initiate endodontic therapy. Occlusion should be adjusted and relieved. During endodontic therapy, heavy dose of anesthetic may be required to attain required depth of the anesthesia, and prescribe analgesic and anti-inflammatory drugs like ibuprofen 600 or 400. We go to the pulp necrosis, really because it's an emergency procedure. It is not an emergency procedure. However, the patients may be not sometimes a swelling. And when the patient not the swelling, it will become something worried. And then he came as requested emergency treatment. I have these cases really for the patients came with he constructed for him a bridge. And after like 10 years, he came to me with the swelling. And he is very fear that maybe worried about the loss of the bridge. And this one, when I going for the treatment, the proper treatment for the pulp necrosis is canal debridements. And then in this case, no anesthesia is necessary in most instances, but in some cases, there are still enough pain receptor to cause discomfort during the procedure. And sometimes I got intrapulpal injections just in case if we're doing the mechanical preparation. Ensure removal all necrotic tissue, and thoroughly irrigations of the canal is required. And all this procedure is supposed to be done under the rubber dam. Rubber dam, it is very important. And as mentioned, Dr. Ahmed Midrati last before 3 days, and he really gave the hints of the successful of the endodontic treatment. Is one of the successful is the using of the rubber dam. Also, we have acute alveolar abscess with acute alveolar abscess. It is localized collections of the pus in the alveolar bone of the root apex of the tooth following death of the pulp, with extensions of the infection through the apical foramen into the periapical tissue. Symptoms of this one, local symptom. Tenderness of the tooth removed by continuous slight process. Patients are thrombing severe pain with swelling of the overlying soft tissue with or without tooth mobility. When swelling becomes extensive, it results into cellulitis and the patient's facial change. Systemic symptoms sometimes will be accompanied with fever and irritations. Where can we be located really? Where can we located from where they located this swelling? Submandibular space, mandibular anterior. Sublingual space, mandibular premolars and first molars. The root apices lie below mylohyoid line. Submandibular space is second and third mandibular molar. The root abscess is below mylohyoid line. Lateral pharyngeal space, pericoronal infections from the mandibular third molar. Infraorbital space or canine fossa infection, maxillary canine premolars and MB roots of the first molar. Retrozygomatic space or infratemporal region, buccal roots of maxillary second and third molars. Buccal space, mostly maxillary teeth and sometimes mandibular teeth when the roots apices cross the attachment to buccinator. I have these patients come with the chronic apical periodontitis really. And there you see there is a perical lesions. And then I started doing the root canal treatment as usual without anesthesia. And then after that, the post-operative for 3 months, there is little bit disappear of the radiolucency, but really the patient didn't follow my instruction to come after 6 months to follow up the case. Find the right tooth, endodontic etiology, vital inflamed pulp, reversible, irreversible, or if there is a necrotic pulp. How do we evaluate the pulp? Oh, by the history, clinical examination, pulp vitality test, as told you, cold test, and the hot test. Vitality, since the treatment is different from necrotic, for necrotic and vital cases, we must first determine the status of the pulp in order to get if the tooth is vital or non-vital. And I have this nice diagram that is vital happy, vital worried, vital mad, when you become mad, and recently dead and way dead, and if there is some of the really past discharge. In this case, vital worried, reversible pulpitis, confirmed restorability, it's very important. Sometimes you are diagnosed, your tooth is very badly destroyed, it's not really, not indicate for restorations, don't waste your time, extract the tooth. And then eliminate the cause of pulpal inflammation that will be created for the tooth, and then follow up evaluations of the tooth. While for vital tooth, causes of pulpal inflammation like caries, improper occlusions, fractures, faulty restorations, while the mad tooth, irreversible pulpitis, confirmed restorability, start endodontic treatment, access, pulpotomy, intracanal medicaments sometimes used, and the temporary restoration. While for vital tooth, assume the pulp is inflamed, not infected. The most important is to eliminate the inflammations of the pulp. In this case, we have an endodontic emergency before treatment, under treatment, and post-endodontic treatment. In this case, when the patient enters, we need to ask, where is the pain? When was the pain first noticed? Descriptions of the pain. Any associated tenderness or swelling? Does anything relieve it of the pain by the painkiller? Under what circumstances does the pain occur? Previous dental history, recent treatment, periodontal treatment, or any history of trauma to the teeth. In this case, emergency before endodontic treatment, we have the treats are pulpal pain, emergency of pulpal origin, reversible pulpitis, irreversible pulpitis, and we have the cracked tooth syndromes, emergency resulting from trauma, and acute periapical abscess, emergency of periodontal origin. And this classification is by Carotti, 2004. This will be published, a very nice paper about the emergency of the endodontic treatment. Patients under treatment, we shall looking for the recent restorative treatment, like high filling spots, micro leakage, micro exposure, thermal or mechanical injury during the cavity preparations, or chemical irritation by using of some of the chemicals materials inside the cavity. And sometimes there is electrical effect of dissimilar metals, especially between the amalgam and the gold, when there is also a created. Periodontal treatment, because there is always a chance that some of the numerous lateral canals that communicate with the periodontal ligament are exposed where periodontal treatment carried out. In this case, there is a great relations between the perio and endo, and this will be called periodontic lesion. And also the exposure of the tongue during the cavity preparation, or a fracture of the root or crown, or the pain result of the instrumentation that will be created, acute apical periodontitis, when you go over the apex or pharynx abscess. The crown fracture. Crown fracture can often be avoided by protecting when you're doing the root canal treatment, by protecting the tooth during the endodontic treatment and providing a cuspal coverage following treatment. If the tooth fracture in the vertical plane, the prognosis is very poor. And in this case, like what I showed to you, this is what we indicated for extractions because the patient didn't agree to do the crown. There is also flare-up. American Associations of Endodontists, definitions and acute exacerbations of the periradicular pathosis after initiation or continuations of the root canal treatment. Studies report that 1.8 to 3.2% flare-up will be occur with the tooth. Intraappointment flare-up is characterized by the development of pain, swelling, or both following endodontic intervention. Flare-up, the causative factors of the intraappointment pain compromise medicals or chemicals or microbial injury to the pulp or periradicular tissue, which are induced during root canal treatment. Regardless of the type of injury, the intensity of the inflammatory response is directly proportional to the intensity of tissue injury. The frequency of the intraappointment pain has been reported to be significantly higher in teeth with periradicular lesion as compared to the teeth with vital pulse and normal periradicular tissue. There are medical status of the patients we need also to be to take in our considerations. Like for the diabetic patients, there are more born for flare-ups because they increase sugar content in blood, and uncontrolled diabetes treated only when there is an emergency. And also for the hypertensive patients, care should be taken during giving local anesthesia, and epinephrine is contraindicated, as you know, to give it to the hypertensive patient. Also for the pregnant patients, second trimester is the best time to treat. First and third risk to fetus and patient. Only emergency treatment given continuations of treatment after the pregnancy. Flare-up result of imbalance in host bacterial relations, and mostly Enterococcus faecalis is present in the retreatment case, while the contributing factors for the flare-up is inadequate debridements, debris extrusions above the periapical area, or over instrumentations. Like this case, when you are opening for the flare-up, you see there is a pus discharge before the obturations with some of the bloody content. The treatment of the flare-up is occlusion reduction, the first thing, and then give the antibiotic as a prophylaxis, and incisions and drainage, leaving tooth open for complete drainage for 20 minutes, complete removal of pulp tissue and debris followed by the closed debris with using a very good irrigations under the rubber dam also. Calcium hydroxide therapy, intracanal dressing, and the mode of actions, hydrolysis, lipid moiety of bacterial lipopolysaccharides, and this advantage enabled to kill Enterococcus species, which is commonly associated with the failed root canal treatment. Antibiotic and analgesic relief the pain is indicated, and corticosteroid anti-inflammatory action also, like what I said about the lateral mix to insert it inside of canal. Fornix abscess. It is defined as sudden exacerbations of the previously symptoms periapical lesion. It occurs after instrumentation of the root canal. This phenomenon is not well understood really. However, it is thought to be due to alternation environments of the root canal system space during instrumentation, which activated bacterial flora and created this abscess. The treatment is needed to put the rubber dam. Also, I concentrate on the rubber dam and irrigations, debridement of the root canals, and establish drainage for the tooth. While for the pulpal pain, is continuation of pain following pulp extirpation may be due to one of the following causes. The temporary phenix may be high. This is where always will be advised for the dentist when you are putting the temporary phenix to check the occlusion, because it will be great pain for the patients after going out of your clinic. Infected pulp tissue is present in the canal. Still, there's some infected tissue and great pain. Some of the canal content has been extruded through the apex when you're doing the instrumentations, and over instrumentation of the apex or perforation sometimes of the canal wall, great pain. An extra canal may be misfind it and may be present, which has been not cleaned very well. Post-endodontic treatment, high restoration, overfilling, underfilling, tooth and root fracture. And as mentioned before me, one of the doctors, she gave very good, Dr. Samar Al-Hashmi, about the root fracture. There is something, a phrase called hot tooth. A hot tooth is a tooth that is difficult to anesthetize, and I think this experience most of us will be faced in our clinic, and it's very challenging for us. There is, in this case, there is a special class of sodium channels on C fibrinones as tetrodotoxin resistant. Sodium channel expressions shift from tetrodotoxin sensitive to tetrodotoxin resistant during a neuroinflammatory reaction. And this TTTXR resistant sodium channels play roles in the sensitizing C fibers. This sodium channel resists lidocaine and is 5 times more resistant to anesthetic than TTX resistant channels. Biovacan, potent in these cases. Supplementary intraligamentary or intraosseous injection has been found to be ensure profound anesthesia, and also some type of intrapulpal injection. Cracked tooth syndrome, definitions of the cracked tooth syndrome: a fractured plane of unknown depth and directions passing through tooth structure. If not already involving, may progress to continue with the pulp and or periodontal ligaments. History of pain on release of biting on a particular tooth, often occurring with the food having small hard particles in them. Visual inspections of the tooth crack and transillumination, magnifying loops, dyes methyl blue, and tooth slot more reliable. The cracks will be divided by the Ratcliffe in 2001. There's a type 1, type 2, type 3, type 4. And this is the prognosis depend on no stain, no symptoms, no restorations. It will be just to adjust the bite. While for type 2, no stain, class 1 or 2 restorations, restore, no symptoms. Class 3, stain cracks with mild sensitivity to the sweetness or temperature, restore. But type 4, when there's a pain on biting and release, restore or extract if depend on the locations of the fracture. cracks and vital teeth, urgent care it need, immediate reductions of the tooth from its occlusions by selective grinding, and sharp, intensive pain of short duration during chewing, and no release of the food, on release of the food, even as no pulpal involvement. Treatment of for crack not involving pulp, compromise portions removed, occlusal adjustment, cuspal protections, restorations, composite, sometimes pinned amalgam or cast restoration. Full coverage of the restoration as permanent treatments is indicated, and if a crack involved pulp causes pulp inflammation and necrosis, root canal is advised, followed by the full coverage of restoration by the crown. As a rule of thumb, if the crack involves a root canal extractions, it would be extract the tooth. If the crack involves the pulp chamber only, maybe root canal and restored. I have this case, really, the patients came to me with the crack, if you see here on the pointing. And in this case, I advised the patients before, when I did the root canal to do the crown, but she refused to do the crown. She said it makes collections of the food, and it is not healthy, and like this scenario that every time they give it by the patients. But later on came after 1 year, I found there is crack and she has a pain. And in this case, I am very sorry about the root canal that I did for her. And then I sent it to her. Just she told me put the composite. I put the composite for her, but later on came and she extracted. And also I have like this one, because the patient is educated and she knows what I'm going to tell her about the tooth. I told her this root canals, when we have root canals and we have MOD and big cavity, we need to restore the crown. In this case, after I finished the root canal treatment, she asked me to do the crown, and it is well done, and the patient's in good condition. Cracked tooth syndrome, really, in these cases, I have the patients when a patient came with pain, also in bitings. During my clinical examinations, and I take the history, I found there is some crack here, and then really I remove all the amalgam, and then I go shifted to located where is the crack, and then I do the root canal filling. After the root canal filling, I close with the composite, and then I fill the tooth with composite, and then this is the final root canal treatment here, and then the patient advised to do the crown. And this is the composite filling restoration, and this is the crown, and this the patients came like after 3 years, and everything is good, and there is no complaint. We have the visual, or sometimes we're facing visual or sinus tract. And this is, it means a communications or pathway between the oral environments and the tooth. This may be adjacent to the apex, mid-root, or along the periodontal ligament. These pathways are traced by the gently inserted a piece of gutta-percha into them, and then take an X-ray to locate it where it is this vistula ended. The gutta-percha will follow the fistula to the source of the infection, and usually in this case, the tooth is necrotic. The etiology is also infection, therefore treatment is there to eliminate also the infection, and this is done by removing the necrotic debris. Swelling, an enlargement of the soft tissue, which is often painful, and the etiology also swelling, inflammations, or infections. And when patients present with swelling, unless there has been trauma, infection is likely cause. And this can be more or less confirmed by locating a necrotic tooth in the area. And the patient sometimes coming with feverish. Also treatment depending on the type of the swelling. We have fluctuant swelling, which is fluid filled. And this type of swelling is softer, more localized, and often indurated. There is a central area which is fluid filled. The goal is to remove or drain the fluid in order to decrease the amount of infectious material. If it doesn't occur when the associated necrotic tooth is accessed, surgical incisions and drainage is indicated in this case. And sometimes immediate relief is obtained when you access the cavity and there is a pus discharge from the access of the cavity and to relieve the pain. Also, there is swelling called cellulitis. This is the second one, firm infections. swelling is referred to as cellulitis. The area may be widespread. It does not contain central area as in the fluctuant of area of fluid. Therefore, incisions and ridge is not indicated because it's firm. We cannot get anything from it. We make a spread of infections if you're. There is rationale for incisions for drainage, decrease the number of the bacteria, reduce tissue pressures, elevates the pain, trismus, improve circulation, prevents spread of infections and alters oxygenation's reductions potential, and also accelerated the healing. Retreatment, this other problems. I received some of my friends send me this x-ray and say, Dr. Adi, can you do it the retreatment? I remember the song of Kulthum, الحب انت فين وانت فين انت فين والحب فين. يعني where is the canals where you are going on through? And at the first visit, it may be necessary to remove all of the existing root canal material. It can be very time consuming, like look for the untreated canals, look for the fracture, intracanal medicament, and then put the temporary. But this one, we can do it really as to remove the gutta percha from the tissue inside and then make and use the MTA to close these perforations and go to the canals. But I think this guy has never take X-ray as pre-X-ray to make to show what is the accompany with his diagnosis. And also I have these cases come to me with the fistula. This is what I called you. And there is, they are using the silver points. And then the silver point, I access the cavity with the crown. And then I get out of the silver point. And then I did the obturations for the tooth. And then I followed up the case. And there is post-operatively, after the 6 months, everything is ready and healing will be take place. And there is no fistula and the preapical lesion also reduced. Referred pain may be initiated from inflamed pulp, other parts of body on the same side or in close proximity to another tooth. And sometimes will be used really anesthesia. Like the patient said, I have a pain from upper and lower, maybe we'll give him anesthesia in the upper. And if the pain is subside, that means it's the pain in the lower. Infection of also, there is an otitis media, referred pain, mandibular molars, the joint dysfunction, toothache. Accurately determine the origin of the pain. Radiograph is often used for hair, and in any case of pulpal pain is diagnosed in order to see if there is really preapical lesion or if there is some of the caries extended to the pulp, and after that you can start the routine endodontic treatments. In this case, I will go to the summary of emergency. We have non-odontogenic and we have odontogenic. Non-odontogenic referred pain, myocardials or neurologic or adjacent structure like sinus at TMJ. While for the odontogenic, periodontal, oral surgery or endodontic origin like vital reversible, restore, followed, or if vital irreversible endodontic treatment, go to pulpotomy or pulpectomy, or the necrotic pulp, it might be go to the endodontic treatment, full instrument, incision and drainage, and antibiotic. While for the endodontic emergency, for the necrotic teeth, it will be swelling with non-swelling. Non-swelling, full instrumentations and medicate and close. While for the swelling, there is a fluctuant and versilitis, as I mentioned. For the fluctuant, full instrumentation, medicament close, incision and drainage, and antibiotic. Versilitis, full instrumentation, medicate and close, and antibiotic. Daily endodontic emergency challenge for us, like this one, I got it every day, like the lower 6, and then we'll be ended with this one to relieve the pain of patients. And when I have time, really, I finish in one visit. And the other one of the upper premolars also, we have for left and right, also they came as an emergency, and we are doing all the treatment plan after we do the diagnosis. And also we have the upper 6 for left and right, also the same thing, it is an emergency in these cases. And also we have upper 7, also the emergency of endodontic. In this case, I would like to say, don't really fed up from listening to the patients. In order, when you listen to the patients, you go the correct treatment. You know how to deal with the diagnosis. In this case, I will never give up in endodontic, and I leave you with this something. Look for this, guys. I think it is really, this is what thing that we are never give up in endodontics, supposed to be. I reached to my conclusion, my dear. Knowing what to do and when to do it are as important as how to do. More than 80% of patients who report to dental clinics have emerging symptoms with endodontically related pain. Therefore, the knowledge and the skill of the operator to deal with these endodontic emergencies is highly required of every clinician. An accurate diagnosis, again, and effective treatment of acute situations are an important responsibility and privilege of dental practice. Effective caring and management of endodontic emergency is not only a great service to the public, which the dentists can be proud of, but it's also enhanced the positive image of dentistry. Let us show this guys when he is getting an emergency how can deal. I think he is lucky with this merciful engine around here. Maybe it's easy to do the diagnosis and maybe easy to give the correct treatment to the patient. He is lucky. Thank you very much for your listening and for attending me. And if you have any questions, I have all of my connections. You can contact me anytime. You're most welcome, all of you.
Thank you very much, Dr. Adil. It's really a huge topic, sorry.